Hello, everyone, and welcome to Frontier Nursing University's celebration of National Nurse Practitioner Week. I'm Dr. Lisa Chappell, the Associate Dean of Family Nursing at Frontier, and in this session, we're presenting a panel of nurse practitioners and how they're caring for their communities. Most of these nurse practitioners are working with rural and or underserved patients. Our first presenter Our first presenter is Dr. Mary Ellen Bickerstaff. Dr. Bickerstaff has her DMP. She lives in Olympia, Washington. At Frontier, she is regional clinical faculty and course faculty. She's been an FNP for 10 plus years. So, Dr. Bickerstaff.
Hi, good morning, everybody. So I wanted to present on something that I've been doing for the last year in my community. There is a doctor that has opened up. I work in a rural community, even though I live in Olympia, a smaller town. A doctor that I work with has opened up MAT clinics that are low barrier. I think that most people are aware of the opiate problem now in the United States and the opiate crisis. And MAT prescribing, which is medication assisted therapy, which implies that you're either doing methadone or Suboxone treatment in addition to behavioral therapy for opiate addiction, is really the gold standard for treatment. We know that people with opiate use disorder just don't do very well if they don't have medication in addition to their behavioral therapy and other treatment modules. Um, so kind of the problem now with Suboxone is getting it to the people that really need it. You do have to apply for a waiver. And recently, in the last 2 years, NPs and PAs have been able to apply to get the waiver from the DEA. It involves some training that you have to do, but it's not a huge barrier. Um, so it's been a really, really rewarding thing to be involved in these clinics that are opening up because they saw a real need that yes, there are some Suboxone providers in the community, but it was a pretty high barrier for people with opiate addiction to get in. They either needed to find a primary care doctor that would do that, or a lot of some clinics had opened that were cash pay only and really required you to be able to put quite a bit of money and pay quite a bit of money to get the treatment. So the clinics that I work at now, are low barrier. So they have our drop-in hours. They do not ask the patients to become abstinent from other medications, obvious or drugs. Obviously, our goal is that all of our patients will become abstinent. We hope that they are able to, be sober and stay sober. But a lot of the patients that we see are really unstable and having a really rough time. So it's kind of a no. We only ask that they continue to use the Suboxone, and we only drug screen to prove that they are taking Suboxone. We have peer educators and RN, so it's team-based care. Patients can drop in 5 days a week, and they know it. And like I said, it's a really considered a very low judgment, or as judgment-free as possible as we can make it. We try and meet people where they're at. We don't kick people out of the program. Sometimes if patients are not doing very well and we know that they're not using the Suboxone as prescribed, we do have them come in to do daily dosing, and that we do daily observed dosing for those patients. And then that lasts for a week or two, and then we hopefully go back to them being able to come in once a week or every few days. So I just think it's just a really great model of care. We have over 800 patients that we have come into the clinic now in the past year. Not all of them have been successful. Some of them really struggle, but they always see the clinic as a place that they can come in no matter where they're at, and that they will be welcomed and they will receive the care that they need. But we've also had a lot of success, and that includes people that are, IV heroin users, that are homeless, that have a lot of co-diagnosed conditions and are suffering and have a lot of things, and also it's working people that have been addicted to prescription opiates, can no longer get those from their prescriber, but are really desperate and trying to hold on to their jobs and their homes, and need to come in later in the evening, and later need to be able to drop in when they have work and they can't make clinic appointments during the day. So there's a really wide range of patients, and like I said, it's been a really wonderful experience, just to provide care on this in this way. And that's kind of, I think that that's the model that I talk about. Some of the things that make it really successful is the drop-in hours that do not require an appointment. We have made it easy access for people that are homeless to walk up from the homeless camps or to use public transportations. we have team-based care with the RNs and peer support that provide as much care as the providers. And many of the peer support people are trained now, but are former addicts themselves, and so can really, really relate to patients. And again, help provide that judgment-free atmosphere. And like I said, we don't require people to stop using meth or marijuana. If they're not ready to do that, then we don't ask them to do that. We wait till they're ready. So that is kind of the model. And like I said, it's been a great thing. And I hope that anybody that has even been thinking about getting a Suboxone waiver would really consider doing it, because it's really been a wonderful thing to have in our community, and also very rewarding as a provider to kind of be able to change that conversation and focus on opiate use disorder as a diagnosis rather than as a judgment.
Thank you very much, Dr. Biggerstaff. Any questions from the panel? Dr. Biggerstaff, I have a question. Would you talk about obtaining a waiver?
Yeah, so it is now completely online. That you can do it through SAMHSA, and the AANP both offer versions. It's 24 hours, and it does count towards your CME and your pharmacy hours that you need. It's actually a really valuable training. They really have done an excellent job putting together the modules and how you do that. Once you obtain the waiver, you can apply to treat 30 patients, and after the first year, you can increase that to 100 patients that you can prescribe Suboxone for.
Mary Ellen, I have a question. So if you're in a state that requires cooperative physician oversight, like Florida does the physician that you work with also have to be a Suboxone prescriber?
Yes, and that is actually a requirement for the PAs that have worked in the clinic, is they have to have a collaborating physician that does have the waiver. So yes, that is the rules. That's a good point, because in Washington we're independent practice, so I don't have to have that. But yes.
Right. Okay, thank you.
Hi, Mary Ellen. I have a question. Where would an NP go for this type of training, for the Suboxone training?
You can find information for it on the AANP in their CE Center, and also SAMHSA. So the let's see if I can remember what SAMHSA stands for. Has a wonderful website with lots of resources on how to be waivered, and it's free. You just need to sign up, and it is 24 hours for NPs and only 8 hours for physicians, which isn't totally fair, but there's also movement now in Congress to try and get the waiver completely eliminated and just allow people to prescribe Suboxone. So hopefully that will be coming as a next step.
Thank you.
I do have just a quick comment. It would be really nice if the nurse practitioners that do have DEA numbers would not have to have physician oversight with this opioid crisis. If the physician doesn't choose to do it, it really limits the nurse practitioner in being able to do it if she chooses to do it. So that might be something to think about on a federal level, where we could maybe go for removal of that cooperative practice agreement for Suboxone treatment.
Yeah, and it's interesting. My it is a physician that started this clinic and really has poured her heart into it. She's actually testifying before Congress this next month on the importance of these clinics and trying to use that as a model. And I do know that she has discussed the model of NPs provide about half of the prescribing in the community, and MDs are about half. And so hopefully that will be something that she can continue to kind of promote and talk about. And I will mention that to her as well.
I have a question too. So what are your thoughts on, I'm assuming right now, are most of your patients coming into the clinic like in person right now?
Yes, we do require to have people, and because it's grant funded, I should add that it is grant funded, we can't go longer than 2 weeks without seeing a patient. So they are required to actually come physically into the clinic at this point.
Okay. What are your thoughts on, as the government I know is looking at, like you said, waivers and things like that to do away with, and helping the opioid crisis? What are your thoughts on even having services like this through telemedicine? What are your thoughts there?
I think that would work really well. It's not, as far as being a provider, it's not a very complicated visit. I mean, I think that the social dynamics and a lot of what the other people going on and behavioral counseling is much more complex as far as a medication decision. It could easily be done with telemetry. You know, another thing I didn't mention too is we're trying really hard to make sure that we're getting people right out of prison, and that we actually have transportation where we're driving them from prison to the clinic directly, because it is a barrier. Even, you know, in people that are more rural, it is challenging for them sometimes to get into the clinic if they don't have gas money or they don't have access to a car. So I think that it is an incredibly safe medication, and so I don't think there'd be any reason it couldn't be done with telemedicine.
Thank you.
Thank you very much, Dr. Bickerstaff. That was very interesting and very important work. Our next presenter is Dr. Nita Harris. Dr. Harris has a PhD. She's a family nurse practitioner and a certified nurse midwife. She's also a certified nurse educator. Dr. Harris lives in Fort Mills, South Carolina. At Frontier Nursing University, she is a course coordinator and has been an advanced practice nurse for 14 years. Dr. Harris.
Thank you for that introduction. I am going to share about the clinical work that I do alongside my role as an educator. It's a topic that I am very passionate about, and I am fortunate to be able to bring this into my teaching with students and be able to share with them the work that I do in hopes to inspire them in their care for underserved populations, and as well as to highlight a lot of the barriers to care for populations with low access. So for the past about 5 years or so, I've been a regular provider at Shelter Health Services in Charlotte, North Carolina. Prior to being there regularly, I was a volunteer, so I would volunteer some time, a few hours every month or so. The clinic then received a county grant to actually have a regular provider there. Other than myself and some other support staff at the clinic, our provider services are entirely, up until this point, we're entirely volunteer based. And so I am employed there as a part-time provider to provide a regular face for the patients at the clinic. So Shelter Health Services is a free clinic, and we serve homeless women and children at the Salvation Army Center of Hope, which is a homeless shelter in Charlotte, North Carolina, one of the largest homeless shelters for women and children in the Southeast. We operate as a separate entity from the shelter. The shelter provides us space to run the clinic in exchange for serving the women and children there. We do collaborate on some issues that impact the overall shelter population, especially, for example, right now as we enter into flu season, we will provide support and guidance on how to best deal with infections and how to keep those from spreading when there are those types of things in the shelters. So flu is a big one, flu season. Also, there could be sometimes issues with scabies and other types of infections that are quickly spread in a population like this. And so we try to provide guidance on how to manage the space in the shelter to prevent that from happening as best we can. Last year, we had a separate room for some of our patients, some of the residents that were diagnosed with flu, and they would stay there until they were recovered before they went back into the more common areas of the dorm. Our average census runs at about 400, and sometimes we're over that, and a lot of times we're turning women away or redirecting them to other places. We get a lot of women and children that come from other states, so from New York, Atlanta, they come from all around to this area, and so a lot of times we are trying to find other alternatives if we are really truly maxed out on space. The length of stay varies. Sometimes they're just there for a few days. We've had some residents there for a couple of years. We've seen that the average length of stay lengthen as the homelessness crisis has worsened in Charlotte. The cost of housing in Charlotte has increased significantly over the past few years, where people work in the same jobs can no longer afford the housing that they could afford, 10 years ago. And so while salaries have not increased or wages have not increased very much, the cost of housing has increased because of all the transplants from other major cities that come where cost of living is much higher in those places. So their money that they're making stretches further. So that drives up the cost of housing in Charlotte to a place that we've never seen it before. And it's been really telling in our clinic that that's taking place. About 80% of our patients are African American, so there's a lot of overlap with a lot of the health disparities that we see based on race and ethnicity that cross over with being homeless. So those are compounded very often. So this is just a little model that we have in a lot of our literature in our annual reports that shows all the services that we provide in our clinic. And so we provide primary care. We also partner with other organizations that bring mental health services and substance abuse services into our clinic. We have dental fairs and vision fairs and things like that. And we also do ongoing cancer screening based on the criteria that we use in primary care. So cervical cancer screening and lung cancer screening and those types of screenings we implement as well in our clinic. And so I mentioned earlier that we do have some full-time staff that work there. And so we have 2 full-time medical assistants, and we have a part-time RN that works in the clinic, and we have a full-time RN who oversees the operations of the clinic. So making sure we're well stocked with our supplies, that our over-the-counter pantry is well stocked, hunting down donations from local pharmacies that are giving away over-the-counter products that maybe have just a few dinged areas on the boxes and things like that. And also overseeing our budgets and grants and payroll and those types of things. And then myself, I am the one part-time provider that is there as an F&P. We also have volunteers that come in periodically. We have an orthopedic physician who's retired who comes in pretty consistently once a week to take care of all of our orthopedic issues, which we are very thankful for because there are lots in the shelter, as you can imagine. Patients who have, chronic arthritis from being homeless and the wear and tear that happens with walking the city during the days, just trying to find somewhere to be and not having the best sleeping conditions and so forth. We have a neurologist that comes around once a month, and then we often get rotations of ED residents that come in from the local hospital that come in either once a week or once every couple of weeks to do a short shift there to provide services in that respect. We also do ongoing referrals to community clinics because we really do try to focus our care on the residents of the shelter. And so once they leave the shelter, they're no longer, unless they're part of our extended care program, which we do see some isolated patients there. But we try to make sure before they leave that they are connected with a community, a clinic in the community so that they can continue to get good care after they leave. So I've mentioned a few of the things that we offer. We have an over-the-counter pantry. So a lot of times they're just needing some ibuprofen, some Tylenol, some Mucinex for a slight cold. And so we try to things that they would be able to go into the local Walmart or Target and purchase, but don't have the money to do that. We will often provide. We get pharmacy services, so anything that is prescribed to them at the clinic, we have a relationship with the local pharmacy to provide those at reduced prices. We also connect with a free pharmacy program in Charlotte for any prescriptions that are outside of our budget. So we do try to make sure we get the lowest price possible, but sometimes some medications, as you can imagine, are just far outside of our budget, and so we will refer them to that program. We get free lab services from LabCorp, so any blood draws or pap smear samples that we send, We get those reports back for free. We have a mammogram mobile unit that comes out to the shelter about once a quarter, and they bring out the mobile unit and they do screenings and also diagnostic mammograms as needed. There's a dental mobile unit where there are several hygienists that come and will do cleanings, and then the dentists are there for x-rays and extractions and fillings that they do there in the parking lot on the mobile unit. We also have a mobile unit that does low-dose lung CT scans for those who who meet the criteria for lung cancer risk. And we have quarterly health fairs where we just try to make sure all the residents know that we exist next door. A lot of residents come in and maybe don't know that we're there for the clinic to serve their healthcare needs. So that's a way for us to inform them that we're there. We have a couple of programs that we run, pre-diabetic programs, where they get structured meals and snacks and things to minimize their risk of actually moving into that category of having diabetes. And then I talked about the extended care program where they can, even after they've left, they can come back and get, refills and just get some ongoing monitoring for things like hypertension and diabetes and asthma are big ones that we do extended care for. And then we do a lot of screening and education for PrEP, which is the HIV prophylaxis, and collaborating with the local organization if we do have a positive HIV result. And then these are just some other external programs, lots of vision screening. We have an organization that sends free glasses. So once they have their exam and have a prescription, they will send the free glasses to the clinic for them to pick up. A lot of mental health care coordination that we have counselors there on site to provide that. Substance abuse, we give out books to the kids to reach out and read because research has shown that reading level is a significant predictor of poverty and which impacts healthcare. So trying to take a very early approach, preventative approach to changing that cycle of poverty. And just some other health education, health coaching, and transportation assistance to appointments in the community.
Thank you very much, Dr. Harris. Any questions from the panel?
Hi, Nina. It's Vicki. I have a question. So you're only there part-time. What do they do on the days you're not there? And do you have students that rotate through there with you?
Good question. So on the days that I'm not there or another provider's not there, so the RNs and the medical assistants are doing a lot of screening. And so we do a lot of intake screening. So we are doing cholesterols and hemoglobin A1Cs and so forth. And so if there's anything that comes back abnormal or if there's a need for refills or prescriptions, they will put them on my schedule for the times that I am there, or one of the other providers that might happen to be there. Some weeks I'm the only provider that comes in for those few hours. So sometimes I have a list waiting on me for the folks that they've seen all week.
So are the children there also?
Yes.
Okay, the children are there also. Okay.
Mm-hmm. And we do have students. We usually don't take in nurse practitioner students just because my time there is very limited.
Yeah.
And these can sometimes be very long visits. And so the students, it's often not a good rotation for students who are trying to get their hours in.
Right.
And I've had students ask me about OB hours and things like that. And while I do OB there, prenatal care and postpartum, a lot of times, I can go a couple of weeks and not have a pregnant patient.
Sure.
So it makes it hard to get specific types of visits because of the variety.
Hi, Nina. It's Diane. Wow, this sounds like definitely a much needed service. I just have a couple of questions. One is about the funding sources, and I may have missed this. Can you talk a little bit about how all of this is funded?
We apply for grants, so our executive director is kind of the person in charge of that, getting grants, making sure that the grant reports are updated, and so that we can be refunded every year. We get a lot of grants from private organizations in the community. So there's a local family that is really big in the healthcare, the Levine Foundation, and we get some grants are very small, some are pretty big and significant, and they all come together to help fund the clinic and fund the positions that keep the staff that keep it running. So we're very fortunate, and so we do have some private donations also.
Okay, great. And the other question,
but we don't bill for any insurance, and so it all comes from grants and donations.
have you seen an increase in older women or older adults?
Yes, I don't know if it's been an increase, but we do have a steady. We'll have patients, we'll have residents in their 80s sometimes, and we try to keep a close eye on them because not only are they more at risk for health issues, but sometimes they are taken advantage of in the shelter. It only takes a couple of people who, they're talking to, hey, let's take a trip to the ATM, and we've had to intervene sometimes with some of those older patients because they're a little, they can be naive and they trust, people a little bit, maybe sometimes more than they should. And so we've had to intervene on some of those. But it's pretty heartbreaking when we have those patients there. You wonder where their family is and what happened.
Thanks, Nina. This sounds wonderful.
Any other questions for Dr. Harris?
Yeah, I'm curious. How big would the need be? Do you think if you expanded the clinic and were able to provide care for as many people as could possibly use it? How big could your clinic get?
Oh goodness!
Or the shelter?
We're always getting phone calls from people who want to come to the clinic, and our first question is, "Are you a resident of the shelter?" And when we get those, every time I'm there, we get a couple at least. So I can imagine what they get on the other days when I'm not there. So it would probably be at least double, I would assume. Yeah, healthcare in Charlotte is becoming more tricky, for sure.
Thank you very much, Dr. Harris.
Thank you.
Our next presenter is Dr. Nikita Duke. Dr. Duke is a DNP and a psych mental health nurse practitioner. She lives in Muscle Shoals, Alabama, has been a psych mental health nurse practitioner for 7 years, and she is course faculty at Frontier Nursing University. Dr. Duke.
Thank you for that introduction. So I'm going to speak on with being a psych mental health nurse practitioner. Obviously, we hear in the community, of course, with earlier with the presentation on opioid crises and things like that, the importance of having behavioral health services. And we'll actually begin to discuss over the last 15 months, what I've been tasked to do to implement a behavioral health program within an urgent care company across 4 southeastern states. So one of the things I wanted to show up front is we know mental health is definitely something that is needed in more areas, especially rural communities that may have to travel, an hour at least to get to the local mental health center, and then possibly a 3 to 6 month wait. I wanted to share some of the prevalence rates. Approximately 1 in 5 adults in the U.S., or 43.8 million, experience mental illness in a given year. Suicide is the 10th leading cause of death in the U.S. and the 2nd leading cause of death for people that are aged 10 to 34. That's really young. And this one especially I wanted to share. In 2017, the age-adjusted suicide rate for most rural counties was 1.8 times the rate for most urban counties. So that just goes to show you, whether it's lack of transportation, it's lack of access, lack of providers, also in finding qualified, good providers to take care of these patients. It can really be a hard thing for these patients to be able to get the care that they need. So how do we serve more numbers? So what I have been working on is joining, as I mentioned, with an urgent care company that is in 4 southeastern states, Louisiana, Mississippi, Kentucky, and Tennessee. And within that environment, we wanted to be able to create, if they were to walk into an urgent care, to help reduce even the stigma, right? If they come in, they don't know what they're being seen for, especially in small rural communities, to walk in the door or to be able to see your car parked at a community mental health center. I'm like, oh, what are they there for? No one knows why you're there. You come into the urgent care facility That urgent care facility, because it is so spread, right now there are 102 clinics within the 4 states and continuing to grow. We want to be able to extend that even further and offer not only psychiatric nurse practitioner med management visits, but also counseling visits. To expand that, to be able to reach that many people in that many states, we have set up a few clinics with a live provider. So even myself, I have a clinic day on Tuesdays in Collinwood, Tennessee. And then also with virtual medicine options or telemedicine options, where there is a tablet that sits within that urgent care clinic, and the patient can come into the clinic, check into their appointment, they are triaged in the clinic, and then are be able to open up the tablet and get started on our video platform to see the patient, and still be able to conduct and have the same services had we sat there in person, but being able to have it closer to home, not driving as far. I know for a fact that the community that I serve, I think the last time we looked it up, there was 936 people in the whole town of Collinwood, and they were having to drive at least crossing the line down into Alabama to be serviced, or at least an hour to Columbia, Tennessee to be seen. And with, if you have Medicaid or TennCare, then you're not able to drive across the line to Alabama. They're not going to honor the insurance. So those patients already on limited income, limited benefits, are having to go an hour, and trying to also schedule vans and transportation was definitely things that are factors that people are going to avoid getting the help that they need. And also, again, small community like that, being able to actually seek the services or be willing to seek the services and be afraid of what others may think. So beyond that, I mentioned the benefits of this is obviously the reduced stigma, increasing availability, increasing locations of service available. Also earlier appointment availability. We've been working on trying to increase staff as our clinics grow. We are currently all the way through Tennessee and Kentucky. Every fast-paced clinic has the availability of behavioral health. So there's 72 clinics now with the means to be able to conduct behavioral health services, with a goal of increasing into Louisiana in January and into going into Mississippi in April, to be able to also target those communities as well. And so I know there's 9 existing clinics in Louisiana now and 30 in Mississippi. So we'll really be able to hopefully continue to make a difference there as well. And one of the things was when I talked about staffing as we go into states is also hiring so that we don't have a very far book out. Hopefully we can get in with a therapist with those patients within a week or two, because as we know, a lot of mental health centers and places may have a 3 to 6 month wait, and the crisis is over by the time they get into the appointment, and there's a very high no-show rate with psych evals at mental health centers because of that long wait time. Also a referral source for our family providers that work within that clinic, for our family nurse practitioners and PAs, having that in-house communication, having providers who can and even for myself, communication to be able to see the medical records and to be able to know what the medical medicines are and work as a team, and knowing that their patients are getting taken care of and knowing where their patients are being referred to if they're not showing, being non-compliant. We have that communication source with being with the same company, and also with the same EHR. So it's really one of the things that we hope to continue to grow and hopefully help out more and more individuals. The company takes, all insurance plans right now. For the most part, there are some that don't want to pay for virtual medicine, but hoping to continue to increase our services, and even maybe later in the capacity of having case management services and even future psychological testing and things down the road. And one of our goals as well is to be even offer home counseling as well. So that once the patient comes in and they join in the clinic the first visit, then they can even get counseling beyond that if they are if they meet their criteria or they're appropriate for home therapy. Being able to also do that from home using our platform from a web address or a phone app, or even on your work hour, be able to go out to your car and take your lunch, have your therapy session, and also to be able to go back to work and not have to have that drive, not to have that leave. When being able to still have the services that you need. And those are my references.
Hi, Nikita. It's Vicki. I had a question. Do you have to be licensed to do telemed in all those states, or can you just be licensed? You have to be licensed in any state, correct, that you're doing?
Yes, anywhere the patient sits. So we will have each of our providers, even myself. So I have 4 state licensures right now to compensate for every state. Yes, ma'am, and a DEA also in each individual state. So we have to have all of that.
Oh, wow. Okay. Now, so then does your employer pay for your DEA and your licenses and everything?
Yes, ma'am.
Oh, good. Okay, good. Thank you.
I have a question, Nikita. It's very insightful. Is there, well, I guess 2 questions. Is there a difference in billing for telemedicine versus in-person visits? And then are there special systems that are used for telemedicine to protect from, I guess, encryption and those types of things that protect from a HIPAA perspective?
Right. So for HIPAA perspective, IT security, we do have encrypted. We have the program, the platform that actually goes through IT is set it up individually and has to be on our VPN to work to our personal link in order for it to work. So we are encrypted there. Also, if someone were to take off with one of the tablets that are sent remotely through the community, again, those can be completely erased, encrypted. If they try to change the password, it's not going to work. It'll actually shut down. Everything will be deleted. So that's been a huge benefit to us as well. And then you asked, sorry, what was the first question?
If there are differences in billing.
So the billing, so if you are, you can still do your E&M codes, and then if you do your additional add-on therapies, etc., your place of service changes a little bit. So you'll have a place of service, and if you're working with a community site or a clinic, they may be eligible for a facility fee to be able to have on that end for their services. Like if the MA is triaging and getting the patients ready, then there's a little fee that they can keep there. And then the professional services also are on your billing.
Okay, great. Thanks.
Any other questions for Dr. Duke? Thank you very much, Dr. Duke. That was a very interesting model of care. Okay, our next presenters, and we have co-presenters for the next session. Dr. Vicki Stonegale is a DNP, a family nurse practitioner for 27 years, and is also a fellow. She lives in Davies, Florida, and at Frontier Nursing University, she is a course coordinator. Dr. Diane John is PhD and a family nurse practitioner for 16 years and is a certified nurse educator. Dr. John lives in Hollywood, Florida, and she, at Frontier Nursing University, she is a curriculum coach, and they're co-presenting on their topic.
Hi, thank you, Lisa, for the introduction. So what we're doing is a community outreach program, and it's our local nurse practitioner organization, which is called the South Florida Council of Advanced Practice Nurses. And that really kind of encompasses Broward County in Florida, which is South Florida, which is where the Fort Lauderdale kind of airport, that whole area in there. So it encompasses, we kind of end at Palm Beach and then end at Miami. So we're in between those 2 areas, just to give you a visual of where we are. So we have a pretty large organization that we started about 26 years ago in this area. And I'm the president of that organization. And we really consistently have about maybe 286 members. We recently, well, for many years, we've been involved in kids in distress and just doing a little bit in the community as far as giving things to the community, but not really actually going out and working in the community. But we've always donated the holidays to kids in distress and women in distress. And that has been kind of our 2 organizations that we've worked very closely with for donations at the holidays. But then Dr. John joined us, has been in our council for a while, and she's been doing some community work, and she had me doing some community work with her. And I got this idea on why don't we add a community outreach committee to our board of directors. And so the board agreed on that. And so we made Diane John our chair for the community outreach, because this is kind of her passion, and she's got a lot of the insight as to what the needs in the community are, and she's been doing some work in the community. So she's also been now doing that position for maybe 3 or 4 months, and has other members that are in our organization that are also involved, and they're starting to participate in some of the community events with her. So some of the community events that we are involved in is the Atlantic Technical College. They have a big health fair every year, a community health fair for students that really are in need of supplies, backpacks, anything you can think of that they need for school. They also have a health fair, and then they also have many different events going on that day. They have health screenings, they have vision screenings, they have all kinds of different things. Also, we're doing stuff with the Broward County Public Schools. There's church events that are happening where the church is asking for health fairs to be done. Dr. John will talk to you a little more about some of these. And YMCA, she's involved with the YMCA, and I'm going to let her talk a little bit about that when we get to that section. Feeding South Florida is another community event, as well as the Housing Authority in the city of Fort Lauderdale. And then also being involved with, she's involved as a senior advisory committee with the town of Davie, which is the town that I live in. And Dr. John is very close to me in the community. So she's involved in that. So one of the things with community assistance, as I said, that we've been doing is kids in distress. And we donate about, it depends on the amount of money, of course, in our funds, because we're all membership driven for our funds, but we try to give between $1,000 and $1,500 every Christmas to kids in distress. And then we hold a drive at our November meeting, and people bring gift cards, but most of the time, and gifts they're supposed to bring, but most of the time they bring gift cards. And then I usually go over there and present them with all of this information, or all of these gifts. And it's so interesting when I go to Kids in Distress. It is a facility that's right outside of Fort Lauderdale in a town called Wilton Manors. And it's a huge building, and they house, I think, 100 children in this building that have been removed from the homes for abuse, sexual abuse, physical abuse, mental abuse, and these kids have nowhere to go. So they're placed in this area, and it's beautiful. It's a beautiful facility. They have their own bedrooms. They have a lot of community involvement with others in the community, as far as physicians and psychiatric and social work. And then they also have the ability to continue to go to school. So when the first time I went there, they had me go in the back to this huge building. It's a huge warehouse. And when I went in there, it was just loaded with, just to the ceiling, with toys and all kinds of supplies that these children need. And they, at the holidays, what they do is they have probably 50 volunteers in there sorting everything out. So they take these donations in all through the year. And then they sort them out. And it was very interesting, because I took my grandchildren there, and, we never think about, we think about our kids having everything, and we don't really they don't think about other children not having everything. So I had them go each buy a couple toys, and took them with me to deliver the toys and the money to kids in distress. And when my grandson went in there, my youngest one, he was looking around, and he was just in awe. I don't think he understood what was going on until I had the lady explain to them what they do there. And then when we went to leave, he said, "Oh, Nana, I don't think I want any Christmas presents this year. I think you should give them all to kids in distress." And so it was kind of an emotional thing. Of course, then we got down the road a little ways, and he said, "Well, maybe I'll just take one gift." So he wasn't going to give up everything, but he did see, I think it was really good for them to see what other children have and what the community does for children. And so every year they want to go, and they want to take those gifts to those kids. Women in Distress, we donate the same amount of money to Women in Distress in Fort Lauderdale. They have a huge, beautiful facility. And it's gated. You can't, and both of these places are gated. You can't get in unless you're invited in and you have security, go through security and everything. But the Women in Distress building, they have a chapel in there. They have physicians, they have nurse practitioners that volunteer. They have social work, psychiatric, they have all kinds of things. And it's a little more secured in that area, I think, because of the individuals who have been abused. They're worried about their abuser being able to find them and contact them. So it's very anonymous. Anything that you go, when you go in there, you don't know who anybody is, and you're not even allowed near those areas. You have to stay in the main areas of both of these places. So we work very closely with them in donating. And so now we will continue to do that also. So this is a community event that Dr. John and I went to. It was the Atlantic Technical College Community Health and Wellness Fair, and we went in August to this fair. And Dr. John was doing blood pressures at a booth. There were multiple things going on there, and our council, we took and delivered. I can't even remember the amount. I want to say it was maybe 110 backpacks for the students with. We had boxes and boxes of crayons and pens and pencils and notebooks and binders and everything you can think of that we were able to fill 100 of those donated bags for the students to be able to take back to school. But one of the things they asked Dr. John and I to do was to talk to the LPN students there. And these LPN students are getting ready to come out in the community, take their exam, come out in the community and practice. So they really don't get a whole lot on professionalism in nursing. I think we get a lot of that in RN programs, but we don't see that a lot in the LPN programs. They get a little bit of a professional role, but not much. So we talk to them about professionalism in the community, what their license means, how precious their license should be to them when they get out and they decide to go back to school, what that RN license would mean, and how they are looked at differently in the community because of who they are now and because they carry the title of being a nurse. And so it was very enlightening, I think, for them to hear what we had to say. I sit on the probable cause panel for the Florida Board of Nursing, and I chaired the board for 4 years. So I really brought up a lot of things that could happen to them if their license got disciplined and how they might lose their license. And these are some of the things, they don't think about getting in the car after they've been having a few drinks with their friends at night, and then they get in the car and get a DUI, and how that can affect them from moving forward with their education, and how it will affect them if they have a current license and what can happen to that license, and discuss the intervention program for nurses that we have in Florida. So it was very nice to be able to share some of that professional role type of thing with these LPNs who are just really entering the role of nursing and don't get that. And then I'm going to go ahead and turn the rest of the presentation over to Dr. John.
Thank you, Dr. Stonedale. So you don't have to be around as long as I have to experience what we sometimes call the revolving door. So if you're in some type of a clinic setting or any setting where you're seeing patients or clients, you may feel some frustration that you're not really making a difference, that they're not really getting it, and what else can I possibly do to improve outcomes for these individuals. And so I've been working in the community for a long time. As a matter of fact, there's a park down the street from me, and I will occasionally drag my little table and chair down there and sit in the morning with a blood pressure cuff and stethoscope, and people stop by and I would take their blood pressures. And, and then they'd ask me questions, not so much health related, but, do you know where I can get some affordable housing? Or, do you know where, what can I do with the food that I have? Because, yes, my provider does say, eat healthy, increase your fruit and vegetables and all of that. but that's just not possible for me. So what can I do with what I have? And so I received a grant last year to be able to help people in understanding and change behaviors associated with poor health outcomes. And with that grant funding, I was also able to educate nurse practitioners, NP students, and community health workers in this how to utilize this change talk and helping people to change behaviors. However, there was a whole nother level of learning, which I think was more on the side of the healthcare workers. You know, we go into communities thinking that, you know, we have the answer, we're going to do a community needs assessment and all of this piece and be able to provide what the community really needs. Well, it's just the opposite. You know, I think that we need to be able to find out what it is that they have in the community and how do we improve in that so that we can improve healthcare outcomes. And the reason I talk about that particular piece is because this photo was taken at a church event. And so one of the things that we do to get people to come to our table to receive information is we do blood pressure. And so almost anybody can do blood pressures, right? So healthcare providers out there doing blood pressures does not seem that significant. But it is, because it gets people to your table. And candy also gets them to the table. And toys for the children will also get them to the table because they come to these events for children. And so the kids are interested. So the kids are interested. The adults are there. So now you've got a captive audience. And so you can see here that that's me on the left. The other two adults are members of the NP Council, and then we have an NP in a coming up NP, that one little one there. She was the child of one of the women. And so what we decided to do was to take a little bit of approach to what we normally do. And so if you can see that little poster board behind us, it says, what is your target? So for every blood pressure that we took, we did like a little stick pin, and so we put a pin there for the systolic, a pin for the diastolic, so that we could get a snapshot of the community. And so the thing about this community is that it's predominantly African American. It's in a low socioeconomic environment. So what would you expect, you know, just based on what we read about in the literature? You know, we were expecting that we would see higher blood pressures, you know, among this particular group. Well, we were surprised because out of the 50 plus blood pressures that we did, less than, I would say 1% of them were high, you know, outside of normal range. And so we were a little, you know, surprised by that because, you know, the literature tells us blah, blah, blah. But then someone said, well, you know, it's probably because, you know, they were coming to the health event, so they probably come with these health-related behaviors anyway. And so there's a good argument for that. But, you know, it also told us that, you know, we should not really go into a community all-knowing. And this is what I get from the community partners that I work with. When I received this initial grant and I was contacting all these people with this wonderful project that I had about motivational interviewing, they were like, okay, so you'll come here, you'll do what you need to do, and then you'll leave. And I said, well, that was what I was originally thinking, but, you know, that didn't happen. I've developed these lifelong, long-lasting relationships with the YMCA, with many of the churches, with feeding the homeless, you know, all of these different programs out there in the community. And I've learned so much, and I've been able to share that with many of the healthcare providers, not just nurse practitioners, but many other healthcare providers who are interested in knowing what truly goes on in the community. You'll see here that I have something about first responders. You know, one of the things that I'm always targeting, or a particular group that I'm always targeting, are our first responders, because at all of these health events, you know, we have the security and we always have the people there, you know, from the fire department in case there's a crisis, and we have police and whatever. So we go over to them and bring them to our table and talk about their health and some of the concerns. And Nikita, this is where we really find the need for, and I hate to just target you, Nikita, but you talked about behavioral health. But, there's certainly a need for behavioral health for our first responders. And I'm always asked by community organizations and representatives from the community, can we provide some mental health services, or is there someone who can come and talk to people about different mental health issues? Because as Vicki said, that's one of the things that we also do. We, we do different presentations. I do an annual presentation for an elderly group, and they love it. And guess what? I do very little of the talking. I just put a little PowerPoint slide up there, and I put a word there, and there they go. They start talking, and they share information and resolutions and interventions and all of this other stuff. So definitely a need for all kinds of services in the community. And so the other thing that I find in working in the community is that you always find others who are working in the community, right? So I've been able to collaborate with so many different organizations, and in collaborating with those organizations, I have this little pocket of resources. So if someone comes to my table in need of something, I can always say, well, I know that this organization does this and this one does that. Because let's face it, our clients and patients, if their needs are not met, then it's futile for us to try to prescribe medication and suggest that they go to therapy and eat right and all of these different things when, we all know about Maslow, where that's kind of like on the bottom of their list. So that's another very significant piece about what we do when we go in the community, is that I also have a list of other resources to be able to meet whatever needs that they have. So this Handbags for Hope, I met a lady in the community who was passionate about, helping a population of women who are escaping domestic violence, sexual assault, human trafficking, poverty, and just life issues. And what they do is they collect handbags for these women, because what woman does not like a handbag? And so the council, during our annual conference, Dr. Stone Gale actually put some information in there that, during that particular conference, for the attendees to bring handbags. And we ended up with, I think it was 65 handbags being donated. And I mean, like some really good ones, like Dooney and Burke and Coach, and some of those other designer handbags that all went to these women, just to kind of brighten their day just for the moment. I've had collaborations with the Filipino Nurses Association, the Nigerian Nurses Association, and we all work together, for the same goal, to serve the needs of the community and to hopefully improve healthcare outcomes, in addition to just increasing awareness about what it is that advanced practice nurses do. Because I get that question also, like, what do NPs do? What do CNNs do? What do mental health practitioners do? What do they do? Oh, there was an NP in my office, but I didn't go to that person because I didn't know anything about him. It's a nurse. I'm like, yeah, they are nurses, and they're also providers, and we look at the whole person. So I've been able to educate about, the professionals and what it is that we bring to the table as far as healthcare and many other needs are concerned.
Any questions for Dr. Stone Gale or Dr. John?
I just want to say that I think by adding this this community outreach to our organization is going to make a huge, huge difference in our community, not only with being able to know what nurse practitioners do and expose the community to nurse practitioners, but also just for the means of being able to provide some type of screening for these people and giving them resources to go to. So we're so excited to have this as part of our organization now.
And, I think the other piece of that, to, kind of wrap it up, is, there are places for all of us. I see a lot of nurse practitioners, and they're like, I can't find a job in the clinic, and I can't find a job in an office. And so I'm like, have you thought about creating your own? There's just such need in the community, and Dr. Harris, you're a good example of that. You started out thing, which led to something else. So, I encourage people to think outside the box, and create something for yourself and meet the needs of those in the community, which can occur, and we can really have an impact on outcomes outside of those four walls in which many of us practice.
Thank you very much, Dr. John and Dr. Stonegale. Would anybody else like to add anything before we close? Okay. Well, I'd like to thank those nurse practitioners who have participated in the panel. Your work is very impressive and really shows what you can do and the avenues that we can care for our communities. I hope that you found this enjoyable and you've learned some things about the role of the nurse practitioner, and I hope that you have a great Nurse Practitioner Week.